Okay, can you see my screen right now?
تمام يا دكتور.
Okay, so the thing that you need to know about the pathology, that it's not focusing on the clinical aspect of the disease. It's focusing on the pathological changes that happen in the eye, and I'll try to correlate that and apply that to what we see in the patients. Okay, but while you are studying, you need to first know about the disease, for example, a diabetic retinopathy, and then focus about the pathological changes that occur in the retina in diabetic retinopathy, etc. So what we'll cover is the retinal degenerations that will not predispose to retinal detachment, and then those who will predispose to retinal detachment, and then we will discuss the retinal breaks, different types of retinal detachment, rhegmatogenous, tractional, exudative. We will discuss the ischemia, retinal artery occlusion, and we will discuss the age-related macular degeneration, and then we will talk a bit about the most important retinal dystrophies, hereditary retinal dystrophies. One of the important things that you will need to know that there is something called the retinoschisis. The retinoschisis is a disease that may occur in some patients, and it is differentiated from retinal detachment. Sometimes we find a patient with bilateral splitting of the retina that looks like a retinal detachment like that, but it's not a true retinal detachment. It's just splitting of the retinal layers. There is no retinal traction here, and this is why there is no photopsia, and there is no flashes, and there is no floaters. It usually starts in the peripheral retina and then extends centrally. It's more common in patients with hypermetropia, and usually you find it in the inferotemporal retina, and usually it's symmetrical, so you find it in both eyes. The surface is smooth and not corrugated like patients with rhegmatogenous retinal detachment, and there are two types of retinoschisis. They differ according to the location of the splitting of the retina. So we have what we call the typical retinoschisis, in which the cystic spaces and the splitting occur in the outer plexiform layer, while in reticular retinoschisis, which is less common, the cystic spaces occur in the nerve fiber layer. If we look at that histological section, this is why I tell you the pathology focuses on the histological section and the pathological changes in the eye. So if we can see here, this patient has typical retinoschisis that occur in the inner retinal layers. So this is the sclera. This eosinophilic part is the sclera. This brownish part is the retinal pigment epithelium, and this is the neurosensory retina. If the splitting is occurring in the inner retina, in the outer retina, so towards the retinal pigment epithelium and the sclera, in the outer plexiform layer, this is called the typical retinoschisis. If the splitting occur in the nerve fiber layer, this is reticular retinoschisis. Clinically, it's a bit difficult to differentiate between them, but usually patients with reticular retinoschisis, they have what we call a thinner inner leaflet. So the inner leaflet, it doesn't have much layers of the retina, so it appears very thin, while in patients with typical retinoschisis, the inner retinal layer appears thicker because it contains more retinal layers. Okay, the complication rate is higher with reticular retinoschisis. We know the main complication is to have a break in the inner retinal leaflet, so a break in this layer, and another break in the outer retinal leaflet, and these can communicate and cause retinal detachment. This is more common to occur in patients with reticular than with typical retinoschisis. Okay. By the way, if you'd like to ask about anything, just interrupt me. That's fine. Okay. Another retinal degeneration that does not predispose to retinal detachment, it's called the paving stone degeneration. Sometimes when we are examining a patient, we find this appearance very far peripherally near the ora serrata. The pathological change that happen here is there is occlusion of the choriocapillaris and loss of the outer layers and the retinal pigment epithelium. So again, this is the sclera. This eosinophilic part is the sclera, the collagen of the sclera. This separation occurs during the preparation of the specimen. So, you know, they take the specimen, they put it in wax, and then they will add formaldehyde and add stains to stain it, and then they will examine it under the microscope. During the processing of the tissue, there is separation between the retina and the underlying sclera. This is the retinal pigment epithelium, this basophilic part here. This is the retinal pigment epithelium, and this is the continuation of the retinal pigment epithelium. So this area corresponds to this pigmented part here, pigmentary part here. And the part in between the two arrowheads is the part corresponding to the area of the paving stone degeneration. There is ischemia of the and occlusion of the choriocapillaris with subsequent loss of the outer layers of the retina and the retinal pigment epithelium, giving this appearance. This cannot predispose to retinal detachment, so it cannot progress to retinal detachment. Another one is the peripheral drusen. It's very similar to the central drusen, but they are present peripherally. This is considered one of the retinal degeneration, but it does not predispose to retinal detachment. As you may know, the drusen is nothing but accumulation of the lipofuscin pigment underneath the retina. Let's talk about the important stuff. So the lattice degeneration is one of the peripheral retinal lesions that predispose to retinal detachment. This is how it looks clinically. It's important, very, very important to know what are the pathological changes occurring in the lattice degeneration. So we have discontinuity of the inner limiting membrane. If you can see, this is the normal retina. This is the inner limiting membrane occurs at that part. In the area of the lattice, there is discontinuity and loss of the inner internal limiting membrane, sorry. And there is atrophy of the neurosensory retina. So the retina, this is the normal thickness of the retina at that part, for example. But at the area of the lattice, the retina is thinned and atrophic. The vitreous overlying the retina, it's known that it's common to develop U-shape or horseshoe retinal tears at the edges of the lattice because the vitreous is tightly adherent to the retina at that area. So if you have a patient that is developing PVD, a posterior vitreous detachment, the vitreous will detach over that area very easily and nicely. But at that part of the lattice, because the vitreous is tightly adherent at that part, the vitreous is tightly adherent, and at that part, the vitreous is tightly adherent to the retina, it will cause a retinal tear, and this can predispose to retinal detachment. Those white lines, as you can see, there are those white arborizing lines. They represent sclerosed blood vessels. So the blood vessel becomes sclerosed and atrophic and whitish in color, and they appear like that. This hyperpigmentation, the blackish color there, is due to retinal pigment epithelial hypertrophy. So there is increase in the retinal pigment epithelium, and this predisposed to this dark coloration of the lattice degeneration. Sometimes we may find snowflakes. Can you see these white small dots over the cursor? This one, this one, this one. This represents degenerated Muller cells. Sometimes the retina is very thin and atrophic and can have atrophic holes, and this is another type of break thing that can develop at the lattice. So we can have a U-shape or a horseshoe retinal tear, or we can have atrophic holes, and both of these tears can predispose to retinal detachment. Okay? If there is anything that is not clear, please interrupt me. Okay? Another retinal degeneration that can predispose to retinal detachment is the snail track degeneration. It looks like as if a snail was moving over that part of the retina. So there is what we call a tightly packed snowflake. So it's very similar to the snowflakes, the degenerated Muller cells that we saw with the lattice degeneration, but they are tightly packed and they have this track-like appearance. It's more common to have retinal holes here because the retina is more atrophic. It's not common to have retinal tears because the vitreous is not tightly adherent to the edges of the snail tract degeneration. Okay. There is what we call the white with pressure and the white without pressure. Those appear something like this, a whitish area of the retina that may appear while we do scleral indentation only, when it's called at that time the white with pressure, or it may be easily seen without indentation and it's called the white without pressure. So it's common to find it at the posterior border of the areas of lattice or the areas of snail tracts, and there is the main problem that there is strong adhesion between the vitreous and the edges of the white without pressure. So when the vitreous is detaching, it will cause a tear at the area of the white white with pressure or the white without pressure. It's important, as we will see later on, the white without pressure is very similar, but it's easily seen without indentation. And again, the main problem that the vitreous is strongly adherent to that part. If you find a patient with a giant retinal tear in one eye, you will go and treat that. But it's important to examine the other eye, because if there is a white without pressure, it's very prudent and wise to do laser treatment at that area, because we know that the vitreous is strongly adherent to that part and the risk of having a giant retinal tear in that eye is high. And it's good to treat the area posterior. Posterior means towards the posterior pole. So the optic nerve is here, for example. This is anterior towards the ora serrata. This is posterior. So we go and treat the posterior edge of the white without pressure with prophylactic laser treatment. Okay, is that clear for you? Okay, another retinal lesion that may predispose to retinal detachment is the myopic chorioretinal atrophy. So a patient with high myopia, you find this white scalloped area. Can you tell me what are these reddish lines? Who can tell me what are these reddish lines?
The choroidal blood vessels.
Those are the large choroidal blood vessels. So we have atrophy of the retina, atrophy of the retinal pigment epithelium, atrophy of the choriocapillaris, atrophy of the large choroidal vessels, and what we can see, the whitish part here, is the sclera. So we can see the sclera and we can see the large choroidal vessels. Those are going to the vortex vein to drain outside the eye. The main problem that the retina over these parts are very thin and ischemic and can develop atrophic holes. And it's difficult to visualize the atrophic holes because the background is white. It's difficult to see white against white or transparent against white. It's easier to see the atrophic holes if there is a bit of contrast, like on that area of the normal retina, but it's very common to have atrophic holes in those parts, and this is why it's very, very difficult to detect and treat them.
دكتور وانا هفرقها ازاي عن الديمايلينيتد نيرف فايبر؟
The demyelinated nerve fiber layer, usually they appear as thickened retina and not thinned out retina. They are usually close to the optic nerve head, so you find them extending from that part and that part. And you will find that the myelination, the myelinated area, is actually covering the retinal details. So they are covering the retinal blood vessels because the nerve fibers are overlying the retinal vessels. Here, it's again whitish, but it's not, it's more described as scalloped edge. So it's like the areas that are more rounded or ovoid and not elongated like the myelinated nerve fiber layer. They may occur near or away from the optic nerve. I mean, I'm talking about the myopic chorioretinal degeneration, and the blood vessels are clearly passing over them and not covered by the lesion like the myelinated nerve fiber layer. Okay.
تمام يا دكتور.
Okay, so let's move on to another entity, which is the retinal break. So the retinal break can be either a retinal tear, and the retinal tear is usually happening because of a strong chorioretinal adhesion, a strong vitreoretinal adhesion at certain point. With vitreous detachment, this will pull on the retina and cause it to tear. It's exactly like when you are wearing a shirt and you are passing or you are wearing a trouser and you are sitting on a seat, and there is a bit of like a nail in the seat, and it will hold the fabric of the trousers, and when you are moving out of that, standing up and moving away from the seat, it will tear your trousers. It's exactly the same, but retinal holes, they are different. There is no traction here, and the retina is thin and atrophic. And both of them, the main problem with both of them, that they can give access to the vitreous fluid to pass underneath the neurosensory retina and dissect it from the retinal pigment epithelium, what we call the rhegmatogenous retinal detachment. The shape of the retinal tear may vary. So we may have a horseshoe retinal tear, which is very, very common. So we have vitreous adherence at that point. That area was supposed to be here, but because the vitreous is pulling on that, it will cause that horseshoe or U-shaped retinal tear. Here we have got another tear. Again, the vitreous is adherent to that part, and with the vitreous detachment, it will pull easily from these areas until the point of the adhesion. It will pull and pull and pull. It's not leaving the retina, and then it will tear the retina and give this horseshoe retinal tear. Sometimes the retinal traction is continued, and the area of adherence will tear all around. So it will not be a horseshoe retinal tear, and it will move to another entity called the operculated retinal tear. So the vitreous is adherent to that part of the retina. That part was attached to this area, and with traction, it progressed to a horseshoe retinal tear, and then with the continued traction, it is torn completely all around, and it changed to an operculated retinal tear. And we call it operculated retinal tear because it has an operculum, a cover like a lid of a jar or something like this. Okay. Sorry. Sometimes we have what we call the giant retinal tear. So as we saw in the white without pressure, if we have a large lesion and with large area of vitreoretinal traction, it may cause a large area of the retina to tear. And this area, this is the ora serrata. The optic nerve is here. Because that break is very, very large, the area will fold posterior like that, and this is called the giant retinal tear. If it's more than 3 clock hours, it's called a giant retinal tear. The main problem with the repair of that giant retinal tear, that you need to unfold the retina, put it back in place first with perfluorocarbon liquid, and then you should treat it afterwards. While in those horseshoe or operculated retinal tears, the retina is still in more or less in place. It's not folded, and there's no need to unfold it. Okay. There is another entity called the retinal dialysis. This is called a retinal dialysis. The retinal dialysis usually occurs after trauma, usually occurs in young children. How to differentiate it from the giant retinal tear? There is no anterior leaflet. So here as you can see, the retina is torn at that part. We have got a posterior leaflet, this one. We have got an anterior leaflet connected to the ora serrata. Here, there is no anterior leaflet, and the vitreous is adherent to the retina. The retina is torn is detached from the ora serrata. The main difference that the vitreous is detached here, so you need to treat it with vitrectomy and PFC and reposition of the retina first, unfolding the retina first, while here the vitreous is still adherent to the posterior edge of the retina. So it's unwise to go and do vitrectomy because it will be difficult to separate the vitreous from the retina because it's still adherent. There is no vitreous detachment. So we treat the retinal dialysis with scleral buckles, and we treat the giant retinal tears with vitrectomy. So again, the retinal breaks are more common to occur in the upper retina, usually the temporal retina. They may be flat, so a patient may come to you with flashes and floaters, and you find a flat retinal tear without detachment, or may be surrounded with subretinal fluid, or what we call the retinal detachment, like this one. The shape, they can be U-shape or U-shaped retinal tears, the horseshoe. They can be operculated, like that one. They can be a dialysis, like that one. They can be a giant retinal tear, like that one. The main problem that when the vitreous detaches from the retina, it separates easily from all those parts until we get a point of strong adhesion between the vitreous and the retina. So it will start to pull pull, it's not separating, it's not leaving the retina, it will tear the retina, and then when we have a break, the fluid will go and dissect the retina from the retinal pigment epithelium and give us this rhegmatogenous retinal detachment. This is an autopsy specimen, so it's a specimen taken from a dead patient. The vitreous is detached from here, but attached to this point. When it pulls, it will cause a horseshoe or a U-shaped retinal tear. I've got a second and a third tears here, and this is a histological section. So this is the normal retina. This is the normal neurosensory retina. The vitreous is adherent to the retina at that point. It will start to separate during the vitreous detachment easily, except at that point was supposed to be connected to this point, and they are continuous like that. It will pull. It's not separating, so it will tear the retina and give this horseshoe retinal tear line. This is the sclera. This is the retinal pigment epithelium. This is the neurosensory retina, this part, and this part. This is the retinal tear, and this is the fluid dissecting the retina from the retinal pigment epithelium. Okay. If we will move to the histopathological findings in rhegmatogenous retinal detachment, we will find that the separation occurs between the neurosensory retina and the retinal pigment epithelium. So the retinal pigment epithelium is still adherent to the choriocapillaris, and the vitreous is adherent to the retina along of the flap of the tear. So the vitreous is still adherent to that point. And we have the separation of the retina from the retinal pigment epithelium. If the retina is not repaired quickly, there will be degeneration of the photoreceptors because they depend on the oxygen supply on the choriocapillaris. When the retina is detached, they don't get blood supply. There is molar cell migration and retinal pigment epithelium proliferation and migration as a trial to repair the damage that happened. In chronic or long-standing or neglected retinal detachment, it's common to find those small cystic spaces because there is degeneration of the retinal layers and the molar cells, and this can grow to macrocysts. Sometimes there are membranes, or what we call the proliferative vitreal retinopathy, as we will see later on. And sometimes we have got what we call the high water or the tide mark line or the demarcation line. This is common to happen in inferior retinal detachments. So if we have an inferior retinal detachment and the rate of progression of the retinal detachment is slow, the retina tries to heal itself. So there is proliferation of the retinal pigment epithelium to demarcate the area of the detachment and prevent it from extending to the central retina. SubhanAllah, it happens as if you have treated this patient with laser, but this patient has never had any laser treatment before. This is a trial of the retina to heal itself and prevent the area of detachment from progression. Okay. So what is the proliferative vitreoretinopathy? The retina is trying to heal itself, but it's a faulty healing. So the retinal pigment epithelium and the molar cells are proliferating and trying to cause fibrosis to hold the retina back in place. But actually this fibrosis is actually making things worse. It's accumulating over the surface of the retina and increasing the retinal traction. It's common to find these star-shaped folds in long-standing retinal detachment or failed retinal detachment repair, and this is called proliferative vitreoretinopathy. Tractional retinal detachment is more to happen with cases with proliferation like PDR, ROP, penetrating trauma. There is vitreoretinal adhesion, so the vitreous is adherent to those areas and it will contract and cause retinal tractional detachment. Here there is no retinal break, but actually the vitreous is pulling on the retina and detaching it from the underlying retinal pigment epithelium and choriocapillaris. The traction can be either what we call antero-posterior traction. So between the area of adherence, we have an incomplete separation of the vitreous. The vitreous is detached at some parts. So the vitreous, you'll find during surgery that the vitreous is detached at this mid-peripheral retina, corresponding to that area, but it's strongly adherent to that plaque, to that area, to the posterior pole. When the vitreous is pulling from the posterior pole towards the ora serrata, this is called an anteroposterior traction. And sometimes when you go and cut the posterior vitreous at the mid-peripheral retina here, corresponding to that area, you'll find that this area will go back a bit because you relieve the anteroposterior traction. And then we have got another type of traction. It's called the tangential traction. So the vitreous is pulling that part to this part. And if you can get access to this membrane and cut it, you'll find that the retina is moving, this part is moving in that direction, and this part is moving towards that direction, because there is what we call the trampoline-like traction. So pulling this point towards that point, this is called the tangential traction. It's different from the anteroposterior traction. Okay, so it's not uncommon to find that the vitreous is pulling in different directions in the same patient. Okay, and this is important during the vitrectomy surgery because you need to relieve all these types of traction. Exudative retinal detachment, there is no break, there's no traction, but mostly there is a tumor. Exudative retinal detachment equals choroidal tumor tail or retinoblastoma tail proved otherwise. So it's characterized by having what we call the shifting fluid. So when the patient is sitting, the subretinal fluid will go at the inferior retina. When the patient is in the supine position, the fluid will shift to the posterior pole. Usually you find the tumor, and when it's treated, we have what we call the leopard spot. So it's looking like a leopard here, and it is due to subretinal pigment clumps that develop after the detachment is flattened. If we'll move to the diabetic retinopathy, what's important here, what I need you to know is the location of each of the lesions. So we have the microaneurysms. Usually they develop as outpouching of the blood vessels in the inner capillary plexus in the ganglion cell layer. These are different type of stain and preparations that stain the microaneurysm and show them. The retinal hemorrhages, those can be either flame-shaped retinal hemorrhages that occur in the nerve fiber layer, and they assume the nerve fiber layer distribution. We know that we have a superior temporal arcuate fibers, inferior temporal arcuate fibers, papillomacular bundle, and the radial fibers at the nasal retina. So if the bleeding occurs in the inner retina, in the nerve fiber layer, this will take the distribution of the nerve fiber layer and will appear as flame-shaped retinal hemorrhages. On the other hand, we have what we call the dot. The small ones are called the dot hemorrhages. The large ones are called the blot hemorrhages. Those occur at the outer retina, in the deeper layers of the retina. And because they occur at the outer plexiform and outer nuclear layers, they assume this blot and dot shaped appearance. And finally, we may have the large dark rounded hemorrhage, which are common to find in cases of ischemia. If there is ischemia, and they represent hemorrhagic necrosis of or hemorrhagic infarcts of the retina. So we have three different appearances of the retinal hemorrhages, and now we know the pathological difference between each of them. Okay. The exudates, the hard exudates are nothing but lipoprotein deposition at the area of chronic leakage. So you have a microaneurysm. The microaneurysm causes leakage with subsequent edema of the retina. At the edge of that edema, there will be deposition of lipoproteins. They appear clinically as yellowish, small, well-demarcated lesions. So you can draw the edges of the lesion with a pencil or a pen. You can delineate it. It's very sharply demarcated. And histologically, they appear as lipid-laden macrophages or lipid-filled macrophages. So this is the macrophage, and the lipid dissolves during the preparation. So we have these clear spaces there. This represents lipids within the macrophages. The macrophages are trying to engulf the lipids, and histologically, we can find that the lipids are present within the macrophages themselves. Those areas represents the microaneurysms, and the retina here is thickened. So we have the retinal layers, thickening of the retina due to the leakage from the microaneurysms. with macrophages trying to engulf the lipid material there. Okay. So
دكتور هو ده غير الدروزن؟ ده غير الهارد دروزن؟
غير الدروزن. The drusen, as we will see later on, is present beneath the retinal pigment epithelium. The hard exudate is present within the inner retina, but superficial or higher than the retinal pigment epithelium. So if this is the retinal pigment epithelium, the drusen will be underneath the retinal pigment epithelium here, while the hard exudate is within the retina itself. Okay.
انا قصدي في الفندس اكزامينيشن هبقى
في
شايفه
الفندس
الفرق ده.
examination in the fundus examination, the drusen will usually appear a bit larger than these ones, and they will appear more grayish and not very yellowish, and usually the context is different. So the drusen will be more they are not, in addition, they are not taking this ring-shaped distribution. So usually if you find a ring-shaped distribution like this one with a microaneurysm in the middle, this is hard exudate. While the drusen, for example, as we saw it later on, they usually appear diffuse like that. There are no microaneurysms. They are not taking any specific distribution. Clinically, they look a bit similar, but there are differences regarding the distribution and the presence of the microaneurysm, and whether the patient is diabetic or not, you can differentiate between them. And histologically, those are present underneath the retinal pigment epithelium, while the hard exudates are present within the retina itself. Okay. Clinically, we have either what we call the leakage maculopathy, so again, a microaneurysm at the middle here over the cursor, or a group of microaneurysms with leakage and with deposition of hard exudate in a ring-shaped configuration around it. By the fluorescein, it appears as leakage, and by OCT, it appears as intraretinal fluid spaces with some hard exudates around it, histologically appearing as fluid-filled clear spaces that are present within the retinal stroma itself. So those are this is the sclera, the retinal pigment epithelium, the layers of the retina, and the cystic spaces are present histologically like that. Ischemic maculopathy is characterized by atrophy of the retina, thinning out of the retina, and by fluorescein you have an enlargement and irregularity of the foveal avascular zone. Cotton wool spots, they appear like that in the inner retina, in the nerve fiber layer. They have what we call the cytoid bodies. So due to the ischemia, there is slowing of the exoplasmic flow. Clinically, they appear more grayish in color and not yellowish in color. They are larger than the hard exudate. They have ill-defined borders, so you cannot draw the border of that with a pen or a pencil. Histologically, they appear as cytoid bodies, swollen ends of the axon seen by light microscopy. Okay, and this indicates ischemia and not necessarily leakage like the hard exudates. The ERMA is present within the retina itself, so there is no penetration of the internal limiting membrane. If it penetrated the internal limiting membrane and had extra retinal growth, this is neovascularization. The ERMA is characteristically growing inside within the retina, and it's not leaking on fluorescein angiography. This is another differentiating point between it and the neovascularization. Ischemia will cause increase in the production of vascular endothelial growth factor with subsequent neovascularization that can happen at the disc, neovascularization of the disc, or neovascularization elsewhere in the other areas of the retina, or it can diffuse anteriorly and cause neovascularization of the iris and neovascularization of the angle and subsequent neovascular glaucoma. Histologically, the new vessels, they have endothelial cells with nuclei. Those are the nuclei of the endothelial cells, those basophilic dots. They grow, penetrate the internal limiting membrane. So this is the internal limiting membrane. The new vessels will penetrate the internal limiting membrane and will grow towards the vitreous. And this is a main differentiating point between the new vessels and the ERMA, the intraretinal microvascular abnormality. Okay, what's the main problem with the new vessels? That they lack the normal tight junctions between the endothelial cells, So they are fragile. They don't form a part of what we call the inner blood retinal barrier. They can leak easily. They can bleed easily, causing more complications. Okay, moving to the retinal venous occlusive diseases, the main change that we have what we call the arteriosclerosis. So the artery and the vein, they have a common adventitial sheath. With chronic and long-standing hypertension, the artery will become sclerosed and not very thin and pliable, and it will cause compression of the vein and what we call the napping of the vein. So the artery will be causing pressure on the vein with subsequent slowing of the blood flow in the vein, and this will promote thrombus formation. We need to know that the pathology of the retinal venous occlusion is usually thrombotic in nature, so there is a thrombus formation, unlike the retinal artery occlusion, which is usually embolic in nature. Okay, this will cause occlusion of the vein with subsequent retinal hypoxia and increase in the leakage and VEGF release. So this is the scenario that happens in patients with retinal vein occlusion. In acute ischemic retinal vein occlusion, there is marked retinal edema. So if you will study the retina histologically, you'll find that there is retinal edema and focal retinal necrosis due to the ischemia, and there is a lot of hemorrhages characterized by extensive hemorrhages, whether intraretinal or subretinal. In long-standing cases, the edema will subside, the necrosis will increase, and there will be some gliosis. So like fibrosis, when it happens in the nervous tissue, we call it gliosis, with some collateral vessel dilatation around the optic nerve head and some neovascularization. We need to know that in ischemic central retinal vein occlusion, the retina is burned out. It's affecting the whole retina. It's not capable of producing new vessels elsewhere or new vessels of the disc. So the VEGF will diffuse anteriorly and cause new vessels of the iris. Central retinal vein occlusion is more common to be complicated with new vessels of the iris and the what we call the 100-day glaucoma. While in branch retinal vein occlusion, only a section of the retina is ischemic, and usually the new vessels develop at the junction between the normal and the ischemic retina. So it's more common to have new vessels elsewhere with subsequent vitreous hemorrhage. This is an important thing to know, the different site of neovascularization in the central and the branch retinal vein occlusion. In the end stage retinal vein occlusion, there is some hemorrhages, some hemosiderosis, iron deposition within the retinal layers that can be detected histologically, and there is disorganization of the retinal architecture. Retinal occlusive disease usually is embolic in nature. There are different types of emboli that can cause this, or it may be due to inflammatory conditions like giant cell arteritis, or due to vasospasm like migraine and hypotension. We need to know that because of the embolic nature of the retinal arterial occlusion, the occlusive disease, it's important to investigate those patients with carotid Doppler to detect if they have a carotid atheroma, which can be the source of this embolus. Okay, histologically, there is extensive ischemia. So in the acute phase, again, there is swelling of the inner retinal layers, but there is no extensive hemorrhages like in retinal vein occlusion. And there is what we call the death of the nuclei or the pycnosis. So the nucleus will appear to shrink and become hyperpigmented, so increased basophilia. And this is a stage that will be followed by disintegration of the nucleus and the death of the cell. This is a term that the pathologist describe the nuclei, that it's pycnotic when it's hyperpigmented like that, and this means that it is degenerating, it's going to die soon. Later on, the edema will resolve and there is an atrophy of the different layers of the retina supplied by the occluded arteriole, and then at the end stage we have the complete atrophy of the retina. Okay. Clinically, it appears like having this cherry red spot. The cherry red spot developed because there is edema of the nearby retina. So the nearby edematous retina will assume a whitish color, will have a whitish color, while in that area, the retina is very thinned out histologically, and it's incapable of developing the edema. So we can see the normal color of the choroid, like this one. We can see it through the retina. And due to the contrast between the normal color of the choroid and between the edematous retina, it gives this cherry red spot. This tends to fade over the time because the edema will subside. When the edema subsides, you will have loss of that contrast and disappearance of the cherry red spot. Moving to the age-related macular degenerations. The hallmark of the age-related macular degeneration is the drusen. So here, the image is inverted. So the retina is here. This is the retinal pigment epithelium, and then the choriocapillaris is upward. It's inverted to the normal OCTs that we see. The drusen is nothing but deposition of lipofuscin material, usually between the retinal pigment epithelium and the Bruch's membrane. So we have the retinal pigment epithelium, and we have the Bruch's membrane, and then we have the choriocapillaris. The Bruch's membrane is the demarcating membrane between the choroid and the retina. The retinal pigment epithelium with aging is incapable of removing the waste material from the neurosensory retina to the choriocapillaris, so it will start to accumulate between the retinal pigment epithelium and the Bruch's membrane. We have histologically two types of drusen, either the basal linear deposits, so they usually develop between the basement membrane of the retinal pigment epithelium and between the elastic portion of the Bruch's membrane. So they develop at that part. We have another type called the basal laminar drusen. It's less common to happen, and it developed at another potential space between the plasma membrane of the retinal pigment epithelium. This is the plasma membrane of the retinal pigment epithelium, and this is the basement membrane of the retinal pigment epithelium. If the lipofuscin material is developing at that potential space, it's called the basal laminar drusen. If they have passed the basement membrane and are accumulating between the basement membrane and the Bruch's membrane, this is called the basal linear deposits or the basal linear drusen. Okay. So
دكتور
how
لما الفرق بين الدروزن اللي هي بتبقى فوق والتانية اللي هي بتبقى بيورد مدفونة؟
لا هي the main difference that the one that we see in our everyday practice, you are usually the basal linear drusen. The basal laminar drusen, they have a characteristic what they call the star-like appearance in the fluorescein angiography. So it appears like a minute, very small hyperfluorescent spots on the fluorescein angiography. It's more seen by the angiography than clinically. But the one that we see in everyday practice, like these ones, for example, they are usually basal linear deposits and not basal laminar deposits. Okay.
أنا قصدي اللي هي البيورد دروزن اللي أنا كنت misdiagnosed فيها مع البابليديما كانت بتبقى البيزل لامين؟
لا, the buried drusen of the it's an optic nerve drusen and not a retinal drusen. So the buried drusen is that's a good question. It's to be differentiated from one of the causes of pseudopapilledema. They are usually present at the optic nerve head. They are more diagnosed with the autofluorescence. So you find when they become exposed, they are autofluorescent. So they will, if you use the filters of the fluorescein and will not inject dye and will take a photo, you find that they are glowing. It's different. It's a different story. It's a totally different story from the retinal drusen. Okay.
تمام يا دكتور.
Okay, so the clinical types, they can be, we have what we call the small hard drusen, the intermediate drusen, or the large soft drusen. How to differentiate clinically between them? So you take the vein at the optic disc margin here, one of the veins, and you take half of the width of that and measure whether the drusen are smaller, equal, or larger than the width of the vein at the optic disc margin. For example, you have these drusen, they are very large and they are even probably 3-4 times the width of the disc of the vein at the disc margin. Those are large soft drusen. and they histologically appear as, so this is the sclera, this is the choriocapillaris and the large choroidal vessels, this is the Brooks membrane, and then we have the retinal pigment epithelium here, and the neurosensory retina is here. There is eosinophilic lipofuscin material that is accumulating between the retinal pigment epithelium and the Brooks membrane. So it corresponds to those drusen. Clinically, they appear as large or, according to their size, grayish yellowish lesion, and they are usually present deeper to the retina, deeper to the retinal pigment epithelium. So if the blood vessels are crossing, you'll find that they are crossing over that area, and they are not in the retina itself. By the OCT, they appear as what we call the drusenoid or the tissue pigment epithelial detachment. So we have detachment or dome-shaped elevation of the retinal pigment epithelium, and we have reflectivity at that part. It's not a clear space. There is some tissue, or the drusen tissue is present there, and it's causing this drusenoid pigment epithelial detachment. Histologically, they have what we call the periodic acid chef nodules, because they are formed of hyaline material between the retinal pigment epithelium and the Brooks membrane. Okay, so PAS stands for periodic acid chef. We have another type of age-related macular degeneration, which is the geographic atrophy. So you have a scalloped area of atrophy at the macula. By the OCT, you find that there is thinning of the retina, and because the retina is thin, the light will pass, more light will pass there, and it will have this back shadowing. And histologically, this is the normal retina, and this is the area of the geographic atrophy. There is thinning of the layers of the outer retina and the choriocapillaris and the retinal pigment epithelium with loss of the photoreceptors. So the pigment epithelial detachment, which is the hallmark of the neovascular age-related macular degeneration, it can be a serous pigment epithelial detachment like that one. This one is more common to find in central serous chorioretinopathy patients. Sometimes it's a drusenoid pigment epithelial detachment like that one. The main difference is that here it's a clear space, there is just fluid. Here there is a hyaline material or a drusenoid material or a tissue pigment epithelial detachment. Sometimes it's due to hemorrhage, like patients, for example, with valsalva retinopathy or macroaneurysm. You may find that there is a bleeding underneath the retinal pigment epithelium. So there is a bit of reflectivity here, but it's different from the drusenoid detachment. It's not very clear like the serous detachment. It's a bit of what we call heterogeneous reflectivity in the OCT scan. And then we have what we call the fibrovascular like that one. Again, there is heterogeneous reflectivity underneath the retinal pigment epithelium with some leakage in the retina or underneath the retina, and this is the what we call the neovascular age-related macular degeneration. So if I find a patient with only pigment epithelial detachment but without leakage, I'll say that this patient is having drusen but with no neovascular age-related macular degeneration. If there is subretinal fluid like here or intraretinal fluid like there, this is neovascular age-related macular degeneration due to a fibrovascular detachment due to a choroidal neovascular membrane. Okay. So we have two important types of CMV on the OCT or on the fluorescein angiography. We have what we call the occult type. This corresponds to type 1, which is more common, in which the choroidal neovascular membrane is still underneath the retinal pigment epithelium. So it's above the Brooks membrane. It invaded the Brooks membrane, but it's still underneath the retinal pigment epithelium. So here, for example, we have the inner layer of the Brooks membrane, and this is the outer layer of the Brooks membrane, and the sclera is supposed to be at that part. So the membrane has invaded the Brooks membrane, and it's growing there. Those are the nuclei of the endothelial cells of the choroidal neovascular membrane. The retinal pigment epithelium is still intact over that membrane. It doesn't have a very well-defined borders on the fluorescein angiography because it's covered by the retinal pigment epithelium. And if you see here, the membrane has penetrated through the Brooks membrane, but it's still not penetrating the retinal pigment epithelium. So the retinal pigment epithelium is intact. The retinal layers themselves are not invaded by the choroidal neovascular membrane, but there is in subretinal fluid. And usually patients with this occult CMV, they have a relatively better vision than patients with classic CMV, in which the membrane has invaded the Brooks membrane and the retinal pigment epithelium and start to invade the neurosensory retina itself. So here it invaded the Brooks membrane, it invaded the retinal pigment epithelium, and you'll find that the retina itself is invaded by the membrane. Usually it's more well defined on the fluorescein angiography because the retinal pigment epithelium is not covering it, but the patient is having mostly worse vision because of the more destructive nature of the membrane on the photoreceptor. A very quick word about the retinitis pigmentosa. It's characterized by loss of the photoreceptor line and increased retinal pigment epithelium pigmentation to give this characteristic bony spicule like pigmentation of the retina. Another quick word about the fundus Flavimaculatus. So again, we have what we call the lipofuscin is lading or is filling the retinal pigment epithelium. So in the fluorescein angiography, it have this what we call the dark appearance of the choroid. The choroid is not glowing because the lipofuscin is accumulation is blocking the underlying choroidal fluorescence. And as you can see here, there is again the periodic acid stain, periodic acid Schiff stain, like the in drusen, and like in cases with drusen, because it's the same material, it's the lipofuscin material, and there is accumulation of the lipofuscin inside the retinal pigment epithelium. So it's not outside the retinal pigment epithelium like in age-related macular degeneration, it's within the retinal pigment epithelium itself. Clinically, we have what we call the macular slime snail appearance, or what we call the beaten bronze appearance. So the scenario that you will see Stargardt disease or Fundus Flavimaculatus, you'll find a young adult patient, a child, probably 10 years, 8 years, 12 years, something like this, coming to you with non-improvement of the vision with glasses. So you try all the refraction that you can do with him and he's not improving. If you'll dilate the patient, you may find nothing and you send the patient to have the fluorescein angiography and he has this dark choroid. Or if you are careful in doing a careful examination, you may see these slight changes in the macula. Okay, and now we understand that it's a hereditary disease in which there is accumulation of the lipofuscin within the retinal pigment epithelial cells. A very quick word about the best vitelliform dystrophy. Again, it's lipofuscin material, but here it's underneath the retinal pigment epithelium. It passes through different stages, what we call the pre-vitelliform stage, appearing more or less normal, no visible changes. Then the vitelliform stage, what we call the sunny side up appearance. So it's like when you are frying an egg, sunny side up. And on the OCT, you find there is tissue pigment epithelial detachment, more or less tissue or irregular pigment epithelial detachment. And then you have what we call the pseudo-hypopyon. So the lipofuscin will liquefy, and by gravity, it will gravitate downwards. And you have a clear space here with lipofuscin material here. So here the scan is from up downwards. So this part corresponds to the part without the lipofuscin material. And this one corresponds to the area with the lipofuscin material downwards. And then you have what we call the vitelli-eruptive stage, in which a choroidal neovascular membrane may develop. And then you have an atrophic end-stage disease. Again, you can find there are pigment cell in the subretinal spaces. and this is responsible for the hyperpigmentation that may happen in the macula at that area. So this will conclude the lecture. I hope it's easier this time. If you have any questions, please don't hesitate to contact me. And inshallah, it will be easier for you this time, for most of you, inshallah. Okay? I'll upload the recording of the lecture to the YouTube, and I will share the link with you. Any questions? Okay.